Management of implant in aesthetic zone. This part is written by Dani Mu'taz and supervised by Dr. Muhammad Waslan. The objective of this systemic review is to discuss the proper way of treatment planning for implant placed in the aesthetic zone and to describe the different types of the remaining tissues and their effect on the outcome. It will also describe modifications of traditional methods and materials used for the horizontal and vertical bone augmentation, and in addition, it will analyze the different approaches of surgical treatment of soft tissue around the dental implant using different types of flaps and techniques during the first and the second stage of implant placement. Chapter 1, Part 1. Diagnosis and treatment planning. In order to place an implant in an ideal position, we need to understand whether there is similarities or dissimilarities between the peri-implant and the periodontal tissue. For starters, let's talk about the osseointegration, which is the direct structural and functional contact between the living bone and the implant surface. The health of osseointegrated implant will depend on the surrounding tissue, which not only anchors the implant but also provides a protective seal against microorganisms. The peri-implant tissue analogs in many ways the periodontal tissue. They both have a cellular epithelium, junctional epithelium, and connective tissue, with the key difference here is that there is no periodontal ligament or cementum around the implant, with the alveolar bone coming into direct contact with the implant surface. Another key difference is the orientation of fibers around the implant and natural teeth. Because of the presence of the cementum, Sharpie's fibers are allowed to be perpendicularly directed on the surface of the tooth, while lack of cementum will cause the fibers to be originating from the crest of the bone to the junctional epithelium in a parallel direction with no direct contact between them. Loss of the periodontal ligament result in poor connective tissue adhesion and poor mechanical resistance to forces. Because of the similar microenvironments, including the sulcus and the pocket, similar effect of bacterial colonization will occur on both of the tissues. But as a result of the structural differences, persistent accumulation of biofilm will produce a more aggressive inflammatory response around the implant, causing the inflammatory cells to be infiltrated up into the bone marrow in comparison with the periodontitis, where the lesions are well contained within the connective tissue compartment. Signs of redness, edema, thickness alteration, increase in probing depth, and bleeding on probing are all pathognomonic of both of the diseases, although bleeding on probing is more reliable around teeth than it is around implants. This is a clinical presentation of a patient who was diagnosed with early periodontitis, and this is his picture on taking X-ray. We can notice how the radiolucency or the inflammation is extending up into the bone marrow of the bone. The healing response of a peri-implant tissue will vary from that of the natural teeth for its compromised vascular supply. The amount of tissue injury influences the speed and the quality of healing. Of course, a small, clean, and closed wound will heal more quickly with little scar formation. Using a mucoperiosteal elevation will result in a post-operative bone resorption. Perhaps the flapless surgery has an added benefit of providing a better vascular supply and retains the vitality of the supracrestial connective tissue around the implants. These pictures were taken from a study to compare between the healing response of a flapless surgery and an open surgery. 15 weeks following the implant placement, the healing response of the bone in the flapless surgery showed better results with minimum crystal bone loss in comparison to the open surgery that needs more time for healing and had a more apical migration of the crystal bone. Dental implant in the aesthetic zone. To successfully place an implant in the aesthetic zone throughout the preoperative diagnosis, treatment planning, and excellent clinical skills are mandatory. Consultation with other dental specialists regarding the periodontal, the endodontic, occlusal, skeletal, and space problems, along with the assessment of patients' expectation, is essential to aid in a long-term prognosis. One of the important assessments to be done preoperatively is the periodontic examination to test both the soft and the hard tissue and to define the gingival biotype of the patient, which classifies how thick or thin the soft tissue and the underlying bone are. The thick tissue is much more forgiving, easier to manipulate, and provide a predictable aesthetic outcome. It usually comes with a flat gingival contour, unlike thin gingival type that is more likely to shrink and cause recession and buccal plate dehiscence, comes with scalloped gingival contour, and when using the probe you can easily see how the probe is showing through the mucosa. Another crucial measurement is the probing depth and the crystal bone level. It's normal to have a probing depth more than 3 mm around the implant. The normal crystal bone is defined as 2 mm apical to the cemento-enamel junction. Picture A shows a thick gingival contour with a high level of the crystal bone since it's attaching the cemento-enamel junction. Picture B is showing us a thin gingival tissue with dehiscence of the buccal plate. Picture C is showing us a periodontitis. Picture D has recession and periodontitis. We can expect to have a vertical ridge collapse after extraction of teeth in case C and D. Other assessments may include the occlusal, the restorative, and radiographic analysis. In 2004, Dr. Teschler proposed guidelines for implant placement in the aesthetic zone, in which the surgeon should apply a conservative flap design, evaluate the existing bone and soft tissue, consider the time of placement correctly, visualize the three-dimensional position of the implant, consider healing time before implant loading, consider the determinants of emergency profile, and select a proper abutment and final restorative design. 4 positional parameters contribute to the success of the restoration. The first one is the buccolingual position, in which 1 mm of buccal wall should be preserved to prevent further dehiscence and gingival recession. On the other hand, placing the implant too far palatally, which may be the case of thin gingival biotype, will require us to use a ridge lab modification that is both unhygienic and unaesthetic. The second parameter is the mesiodistal position, in which 1.5 to 2 mm should be maintained between the implant and the neighboring tooth. In case of multiple implants, then a space of 3 to 4 mm at the abutment level should be maintained to maintain the interproximal bone level and subsequently the papillary height. The third parameter is the apicolingual positioning or countersinking, which is important in hiding the metallic show-through. Countersinking depends on the implant diameter. The wider it is, the less countersinking is needed to create a gradual emergency profile. It's generally accepted to use the cemento-enamel junction of the adjacent teeth as a reference point for placing the implant platform in patients who do not have gingival recession. While in cases of gingival recession, then the mid-buccal gingival margin is used instead of the cemento-enamel junction like in this picture. The fourth parameter is the implant angulation. As a general rule, we can angle the implant to mimic the adjacent tooth if it's properly aligned. Using the surgical stent to correctly visualize the space and angulation is important, and once again, In cases of thin gingival biotype, then a palatal angulation can be anticipated to preserve the buccal soft tissue bulk. This is a picture of CT imaging showing the ideal incisor placement and a CT-generated surgical stent. Interdental papilla evaluation. According to the Palissy-Erickson classification system that divides the implant sites into 4 classes describing the vertical and the horizontal dimensional tissue loss, the vertical loss of a class 1 means that we have an intact or slightly reduced interdental papilla. Class 2 means that we have less than 50% of the papilla lost. Class 3 is severe interdental papillary loss, and Class 4 is complete absence of the interdental papilla as the one seen in the edentulous ridges. For the horizontal loss, Class A means an intact or slightly reduced buccal tissue. Class B is when we have a limited loss of the buccal tissue. Class C is severe loss of the buccal tissue, and Class D is extreme loss of the buccal tissue, often associated with limited amount of attached mucosa. Tissue grafting. The amount of the available bone and the buccal plate will determine the amount and the type of tissue grafting. Moreover, it aids in the decision whether the implant can or cannot be placed at the time of extraction. It is advisable to wait for a few weeks before the placement of a grafting material and after the tooth has been extracted to achieve an adequate keratinized tissues in the area, just like in this picture. If a grafting is delayed, keep in mind that we need to form the papilla with an ovate-shaped pontic, using a bonded tooth, a pontic, or a stable removable appliance, because failure of the papillary support will compromise the long-term aesthetic of the area. Implant placement. The decision regarding immediate or staged implant placement is determined by 3 factors: the absence of acute infection, achievement of initial stability of the implant, and sufficient quantity and quality of the bone that is present. In case of a thin gingival biotype, a concomitant soft tissue augmentation is needed at the time of placement. Generally, if sufficient initial stability is obtained, a horizontal bony defect can be treated using bone grafting procedures with membrane. Cases with extreme bone defect that affect the initial stability, then a lateral ridge augmentation followed by a delayed implant placement is indicated. There is no available surgical approach with satisfactory prognosis for cases with vertical bone loss. Dr. Garber has proposed a classification that depends on the type of the reconstruction needed to get a good positioning of the implant. Garber Class 1 is when we have a favorable horizontal and vertical levels of both soft and hard tissue available. The ideal implant positioning is a straightforward procedure. Garber Class 2 has no vertical bone loss and a slightly horizontal bone deficiency, measuring 1 to 2 mm narrower than normal. Garber Class 3, 4 sides with no vertical bony loss and the horizontal bone loss is greater than Class 2. Guided bone regeneration is necessary in these procedures. Garber Class 4 is in sites with no vertical bony loss but has a significant horizontal loss. It's necessary to use a staged approach in which the ridge is widened using a guided bone regeneration. Implants are later placed after a suitable healing period of several months. The autogenous grafting material is the material of choice for these procedures. Garber Class 5 is the only class that has a vertical bony loss, and it presents a significant challenge to the surgeon. This is the end of Part 1. Thank you so much for your kind listening.